This video is going to be covering the slides for gastrointestinal disorders. So we'll kind of go through this fairly quickly. You know, one nice thing as we start to think about gastrointestinal conditions, pretty much all of us, I assume all of us, have experienced gastrointestinal conditions at various levels throughout our life. So it's things that we're very familiar with, and when they pop up, they're fairly easy to recognize. So common complaints for these, it's the Pepto-Bismol song. It's nausea, heartburn, indigestion, upset stomach, diarrhea, right? So nausea, diarrhea, constipation, some heartburn, right? Your patient will complain of problems along their digestive tract, and usually these are pretty uncomfortable. And we're also pretty good at identifying these because, you know, when we eat things that don't feel good on our stomachs, our body usually lets us know pretty quickly. So just a reminder on the anatomy, we have our esophagus, right? So our mouth and our teeth are part of the digestive system, our pharynx into our larynx, our pharynx into our larynx, and then we have our stomach, small intestine with its three portions, duodenum, jejunum, and ileum with an E, ileum with an E as opposed to the I at the bone, right? This is the end that connects to the colon or the large intestine. Then we're going to have our, let me grab this picture. We'll have our ascending transverse and descending colon. This leads into the rectum, excuse me, and then finally into the anal canal and the anus, which is where we'll finally excrete and defecate our feces. So typically during an abdominal exam, we will break the, I'm just going to come down to this picture. We will break the stomach up into quadrants, and then based on that, we can identify sometimes the pain, and then based on where the pain is in the quadrant, or in this instance, it's broken into 9 sections. Sometimes you can determine what the issue is. So just when we look at this picture here, so right upper quadrant, notice we have a huge portion of the liver here. So if I come up here, we're going to have a huge portion of the liver. The gallbladder is going to be embedded in that. We're also going to have a portion of the small intestine. We're going to have a portion of digestive components, the pancreas here. And then we're also going to get into the colon that you've seen in this picture here. So that colon's going to come up, it'll catch this right upper quadrant and then come across. If we look at this left upper quadrant, we're talking more about stomach, where the spleen is contained in this left upper quadrant. You'll notice again the colon, we're going to have some portions of the small intestine. Excuse me. So when we come over and look here, we're catching that little bit of the liver, the spleen, stomach, a little bit of the pancreas, right? And then a little bit of that colon. If we come down here into the lower quadrants, we're talking much more about colon and small intestines. We're also going to have the kidneys on the back side, so I don't have a picture of that. We're also going to have the kidneys, and then this is also where we start to get into some reproductive anatomy, which sometimes causes problems. So right kidney, cecum and appendix, so that's part of the ascending colon, right? So the ascending colon right there. We have the beginning of the bladder in females, ovary, uterus, and in males, the right spermatic cord, and then that ureter descending from the kidney. Left kidney, sigmoid colon, descending colon, so this is transverse, descending colon, bladder, again, ovary, uterus, spermatic cord, and ureters. Okay, so when it comes to evaluation, what was someone hit? Was there a problem? Was there something that initiated this? Family history, again, just like so many of our general medical conditions, this family history is so important. If you have a family history of Crohn's disease or inflammatory bowel syndrome or heartburn, right? Gastroesophageal reflux disease, sometimes you catch it in the family history, okay? So red flags here, obviously fever. We get a lot of fevers with our gastrointestinal problems because of infectious conditions. We'll talk about that I'll record some videos on that in a later video. But we want to look for bright red blood in the vomit, okay? Because that would indicate blood in the stomach, which is not going to be good. Sometimes that blood will be in there for quite a while, and it will be more of a purple or black. And we also want to be watching for that. You guys know a lot of times when we vomit, it's the color of the recent food we ate. If we vomit continuously, eventually it'll become green, which is the stomach acid that sits in our stomach. So anyway, if we see colors that are distressing besides those, then that could be a red flag. And then persistent vomiting is never good. It leads to dehydration. You guys know it. You can become weak. If it's a smaller individual or a child, then that happens quicker. Additionally, as part of our evaluation for females, we'll want to chat just a little bit about menstrual cycle history, if that seems to be something that should come up during our evaluation, and then any other things that we might look for during our observation. So key questions, obviously it's our regular history questions that we ask. When did it start? How bad is it? When is it worse? Morning or night? Can you describe it? Sharp, stinging, stabbing, shooting. Put it on a scale of 1 to 10. Does it go away? Does it get better? Does it come in waves, etc.? How is it in relation to your eating? Do we see any eating patterns? And then the quality of the pain, does it radiate? How severe is it? Etc. Okay. So in that objective, scars, color of skin, do we notice the patient guarding? And then we can do a partial sit-up to evaluate rectus abdominis, maybe internal and external obliques out on the sides, if we feel like that's in order here. We've talked a little bit about auscultation in the lungs. We did a little bit of it here. So we will listen to intestinal sounds. Again, a lot of us know what this sounds like because sometimes when we're really hungry or when we're really full, our stomach will make these sounds louder and we hear them, bubbling and gurgling. Absent sounds for a long time. So a lot of times if you wake up in the morning and you listen right away, you won't hear a lot going on. But if you go and eat breakfast or drink some water, you'll start to hear some things. But if you don't hear anything, or if you hear kind of a rushing sound like fluid moving through the body, high-pitched tinkling, any sounds besides this bubbling and gurgling are going to be abnormal. Percussion, we percussed the other day, or we percussed in the past with the respiratory system. So dull sound adjacent to organs, and then we're going to hear more of that hollow kind of thudding over the organs. And then this is good. It allows us to kind of evaluate liver and spleen. And then we will do palpation as part of our lab, so light and deep palpation. Right upper quadrant, so here's a location of common conditions: right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant. So this usually relates to the structures in that quadrant, okay? So that duodenum, right? The duodenum, if we come back up and remember the duodenum, just that initial part, right? The initial part, where was I? Here, that initial part of the small intestine. So if that comes off of that stomach right there, it's going to be right in this upper quadrant. So if we notice a problem there, we might have a duodenal ulcer, cholecystitis, keep moving these, hepatitis. This is hepata is liver and itis is inflammation, so inflammation of the liver. And then pneumonia is going to be from the water and the lung sounds. Left upper quadrant, you can see here, abdominal aortic aneurysm. That would be, you would hopefully know that before you listen. Stomach ulcers, pneumonia again, because we're right by the lungs. A spleen laceration or rupture. Periumbilical, I'm going to skip over that abdominal aortic aneurysm again. Early appendicitis, maybe intestinal obstruction. That's going to be pretty common in this middle region. And then right lower quadrant, McBurney's point for appendicitis. This is, again, if we're dealing with females, uteries, ovaries, fallopian tubes in this region. Should be thoughtful of it. Hernia, assuming here this is more of a inguinal hernia as opposed to an umbilical hernia. Cysts, kidney stones, infections, I agree. Constipation, ectopic pregnancy, again, those things. Okay, so talked a little bit about percussion. I'll cruise through that. So acute onset, the spleen. So remember, physiologically, the spleen just holds blood. And when we need a bolus or an injection of blood into the body or into the intestinal tract or etc., the spleen can empty itself of blood. And so the spleen can become inflamed. And if it becomes inflamed, it's pretty superficial on that left upper quadrant. And when it becomes inflamed, if it takes a direct blow or a hit, it can become lacerated or ruptured. And so there's a question here, what commonly causes this in young, healthy people? Mono is a common cause of an inflamed spleen, okay? So in terms of liver and gallbladder, we're going to talk about, it's going to be intestinal problems. So if there's an initial liver or gallbladder acute onset problem, they're going to feel indigestion. They're going to have digestional problems. They'll probably notice their bowel movements and their feces is irregular. We might notice in these individuals that the pain is referring into the back. We may notice a drop in blood pressure, and we may notice a compensating heart rate. Okay, so I'm going to actually stop this video here to keep it brief, and then in another video here, I'll cover conditions.